We have in front of us a question from 2015 November from AIMS. We saw a 30-year-old pregnant woman comes to your clinic with decreased sleep, increased appetite, and hyperactivity for 2 weeks. A diagnosis of mania is made, and further probing reveals 4 episodes of major depression in the past 2 years. So, what drug will you prescribe to this patient? Okay, A. Haloperidol, B. Lithium, C. Promethazine, and D is clonazepam. No, many of you might be thinking the answer is lithium because we have in front of us mania, right? So mania basically created with mood stabilizer, lithium. But the problem is that this woman is 30-year-old pregnant and lithium is teratogenic, right? It is teratogenic. Hence, it is contraindicated in this scenario. Okay, but if it had been a man or a woman of non-reproductive age group, lithium would have been our drug of choice. But since it is a pregnant woman, we cannot give mood stabilizers like lithium or valproate, which are teratogenic. So answer would be an antipsychotic, and the only antipsychotic over here is haloperidol. Although it's not a standard of choice, I would say real life option would be quetiapine or olanzapine. In majority of the perinatal clinics, the perinatal psychiatric clinics, actually majority of the bipolar patients are patients who are having affective symptoms, predominantly like BPAD 1 or 2. They are treated with antipsychotics like quetiapine or olanzapine. Nowadays, haloperidol is not that much favored because of its uh, prevalence, because it has a depressogenic effect. It can induce a switch in the opposite side. Like for example, mania can become depression. Okay, so that is one of the disadvantage which is not there with second generation antipsychotics, namely olanzapine or quetiapine. Okay. So in case you get a question in the future, there is a chance that you might get the options of olanzapine and quetiapine in the future. Just got it. Okay, olanzapine and quetiapine. Right. So what was basically happening? So this is what was happening. Okay. So this lady had 4 depressive mood. Okay, and one current episode. So it is bipolar 1 disorder plus first trimester pregnancy. Okay. So the goal would be anti-manic action to calm the storm, but constraint is absolute avoidance of teratogens. Okay, because of which lithium goes out of the options. Okay, lithium goes out. So plan B becomes our haloperidol in this case, or maybe any antipsychotic, just like we discussed, like olanzapine or quetiapine. Okay, so the haloperidol catches this. It is effectively suppressing mania, but also risks pulling the patient to down. Okay, dangerous prospect for a patient with 4 prior depressive episodes. See, so this is our problem, the depressogenic tendency, which is not there with second generation antipsychotics like olanzapine or quetiapine. Okay, so let's see what is written over here. So haloperidol being the answer over here. So this patient has bipolar disorder for prior depressive episodes and now pregnant with the current uh, episode being mania. Okay, so side effects during pregnancy and lactation. Okay, so teratogenic, possibly increase in incidence of Epstein's anomaly, which is distortion and downward displacement of tricuspid valve in the right ventricle. The side effect which we are also discussed in the PYQ discussion series in lithium, in the psychopharma series. If you haven't seen that, go check it out. You will find such discussions on lithium or valproate and the kind of teratogenic effects, including neural tube defects and external anomaly in that Psychopharma series. Okay, so please check out that series as well. Okay, and Ahuja also talks about contraindications of lithium use during lithium pregnancy and lactation. So with lithium and wife has the same teaching, valproate. Okay, so the use of valproate in pregnancy and lactation should also be avoided, ruled out by teratogenic grounds, and antipsychotic use instead of control the acute manic agency. So this is also written in Ahuja. And Kaplan-Sarnock is like haloperidol is an effective treatment for acute mania. Okay, so it is a second line treatment, by the way. This was written. So Kaplan flags haloperidol as a second line for mania in a non-pregnant patient because of the depressogenic tendency. Always remember that. The first generation. Okay, so this first generation antipsychotic. So haloperidol is a first generation antipsychotic. They have got depressogenic properties. So if somebody asks you whether haloperidol can be used in mania or not, your answer should be yes. Okay, so you can use haloperidol as an antimanic agent, but if somebody asks, would you use it when you have so many other options, then the answer becomes no, because we will prefer second generation antipsychotics. Okay, so why the other options are wrong? So lithium is contained in pregnancy, teratogenic associated with estrogen anomaly in the first trimester. Okay, so the common examples include diphenhydramine, hydroxyzine, promethazine. This is just a sedating antihistaminic, not antimanic or mood stabilizing agent. It would not be treating any underlying mania, by the way. Clonazepam is a benzodiazepine, although can be used in mania, but it is not as such the treatment of mania. Okay, so yes, it's a adjunct treatment with agitation and sleep. Okay, not a definitive treatment for mania episode itself. Okay, so one can combine haloperidol and clonazepam in this case, and haloperidol would become our main drug of choice, with clonazepam acting as an adjunct. Okay, so what do we find over here? So is the patient pregnant? Okay, in acute mania? If no, then we go for standard mood stabilizers. Okay, then we go for standard mood stabilizers. However, if they are pregnant, then we avoid the teratogens. Okay, because of Epstein's risk. Now you use haloperidol in this question, but any antipsychotic, by the way. Okay, and we favor second generation antipsychotics. Okay, among the antipsychotics, we prefer the second generations over the first generations. Okay, so clinical mastery isn't just knowing what a drug does, it's knowing how to weigh against its risk against the alternative. Okay, this is why we are weighing in the risk of teratogenicity versus clinical efficacy in this case, and we are not giving mood stabilizers in this case. Okay, so always remember, whenever a woman with affective disorder like uh, bipolar affective type 1, like BPAD type 1 or BPAD 2 comes to our clinic, we will not give mood stabilizers as they are teratogenic. Mood stabilizers examples are lithium and valproate, as well as carbamazepine, by the way. Okay, what we will prescribe is a second generation antipsychotic, namely olanzapine. Okay, namely olanzapine and quetiapine. Okay, thank you. Hope you have learned something from today's discussion. We will meet in the next section.